taking.
Sorry, I forgot to start the recording. So good, it missed my introduction, but we'll start with Gareth. So
that works. Thank you, Sally. And again, thank you everyone for spending some time today to talk about strategic planning. Thank you for all that you do to help create suicide safer communities throughout Tompkins County. A couple of things to keep in mind as I will go through the workshop this morning. One is, the goal of this workshop is to provide a framework, a structure that you all might consider to then utilize going forward to develop your county's strategic plan for suicide prevention. I wish I could tell you that at the end of this workshop, you would have a completed plan, but 2 hours is just not going to give us enough time. But again, there is a framework, a structure, and as a follow-up to today, I will also be sending Sally some exemplars and some templates that you all could decide to use, if you were so inclined, to help guide that work. I try to find a balance so that what I'm sharing is not prescriptive in nature, because there's any number of different tools and resources out there that people can use in the context of strategic planning. But I also didn't want to put something together that leaves it to people's own devices to have to reinvent the wheel, right? So I'll at least give some examples. Another thing to be thinking about as we go through the next couple of hours is assuming that this is going to go from theory to practice, if you will, after today's workshop, thinking about who are the best individuals to continue to advance the development of a strategic plan. Is it everybody who's sitting in on the call today? Or is it somebody else from your organization that can be part of a structured group to develop that plan, right? And you don't need to answer that now, obviously, but it is something to be thinking about. Are you the person who's going to be part of that process, or would you hand it off to somebody else? The other thing that I think is really important, and Sally mentioned it, and I absolutely second this idea and want to make sure that there is a lot of work that's gone on in the community in the last few years as it relates to suicide prevention. And as Sally mentioned, I have the good fortune of working across New York State with a number of different suicide prevention coalitions and task forces. And I'm sure you've all probably seen on some level that coalitions have sort of a life of their own. They have ebbs and flows in terms of attendance and participation and so on and so forth. And that's just the reality of coalitions. So in terms of thinking about a strategic planning process and an eventual goal of developing a strategic plan going forward, that is not just to dismiss the work that's gone on to date. It's really building off of that infrastructure, building off of the people who have the roots back to earlier stages of the coalition, and people who are new to the table, to take that foundation and just to continue to strengthen it. So enough of the preamble.
Hey, Gareth, can I just, we did have 3 new people join, so I just want to acknowledge that and welcome them. We had Brian Peterson from Ithaca College and Emily Millar, and it looks like Joe Palladino was able to join us. So just wanted to welcome the 3 of you, and we really have just started. Welcome, and again, please just share in the chat who you are and what your role is and what you do for restoration. So thanks again so much to everyone for joining us today.
Yes, thank you, and welcome everyone. So as I go through this, it is a pretty straightforward presentation. That being said, if at any point in time you have questions, if I'm going too fast, which I get on a roll sometimes, I want this to be useful to you all, so please certainly feel free to use the chat function to ask questions. I'll try to monitor that, and maybe Sally, if you could do the same, or feel free to unmute yourself just to pose any questions, and I'll try to make sure we have that opportunity for more formal Q&A towards the end. But with that being said, we're gonna move onwards. So along with the opening chat question to introduce yourself by name and role and something that you do that's restorative in the community, I have found that it's really important anytime I'm doing a presentation on suicide prevention, regardless of the context, regardless of the audience, regardless of the location, to put some reminder that you see on the slide now about keeping calm and practicing self-care. I would imagine that each and every one of you on a good day, on a really good day, whatever defines a good day for you, whether it be at home or at work, whatever the scenario is, right? That even on a good day, you might encounter just the slightest bit of stress that might seep in, right? That's human nature. That's just sort of the way life goes sometimes. There's maybe some small stressors, maybe larger stressors, right? And if that's true, and now we begin to talk more about this idea of suicide prevention, right? Again, regardless of the context, whether it's skills-based training or strategic planning or anything else, whatever the intersection of our personal or professional lives with suicide is, it's really important that we're taking care of ourselves, that we are doing things that are restorative in nature, right? Because not any of us are immune to life happening, right? And so we really need to make sure that we can be at the top of our game so that if we ever do find ourselves in a position to help support somebody, maybe who's struggling with thoughts of suicide, personally, professionally, whatever the case might be, that we are fully recharged, or as recharged as we're able to be. So I could spend a lot of time talking about the importance of self-care and the work that we do. I won't, but I do want to make a reminder to all of us, and a plea really to each and every one of you to be thoughtful and intentional about the self-care that you do, because you're such valuable resources and assets in your communities and your families, with your loved ones, that we can't take this for granted. So I will get off that soapbox now and continue on. So going to do an overview today, and you'll see a lot of circles in this work around strategic planning. We're going to have a 6-step overview of the strategic planning approach to suicide prevention. And I'm going to populate these all at once. These are the areas I'll be covering. And this work was informed by the Suicide Prevention Resource Center, which is a federal resource. It's a clearinghouse for all things suicide prevention related. And it has a wealth of resources and information. And one of the tools that they have is a virtual, online, pre-recorded, go at your own pace module for strategic planning. And so much of what I'm going to be discussing today is based on that. A few years ago, when we started rolling out the opportunity to present on strategic planning for coalitions, we decided that rather than just give a link to this pre-recorded workshop, that we believe there would be value in doing this particular workshop in person and having the potential for some interaction and discussion. Now, of course, in the pandemic world, everything has had to pivot to virtual. And so it's not quite the same necessarily, but there will be some opportunities throughout for a little interaction. But just to give you some background, this is predicated on both the Suicide Prevention Resource Center's strategic planning module and some work done by researchers out of Washington State University, Hawkins and Catalano, who developed the Communities That Care survey and have done some work around strategic planning frameworks. So it's sort of a hybrid, if you will, of those. 6 areas we're going to be talking about, starting with understanding how suicide affects a community, understanding the problem and its context, exploring choosing long-term goals, looking at key risk and protective factors, and with an understanding that by impacting those key risk and protective factors, or what is often talked about as upstream prevention, that can help us achieve our long-term goals, looking at some existing interventions or midstream prevention, or developing new ones to change those key risk and protective factors, looking at evaluation. How do we make sure that what we set out to do, that we're doing in the manner that we intended to, and we'll look at implementation. So again, another circle. Strategic planning is a dynamic process, and it happens on a continuum. And so if today was the beginning of that process, let's say in whatever time period you all have come together and developed the Tompkins County Suicide Prevention Strategic Plan, it doesn't mean that the work is over. On some level, that initial work is done, right? But strategic planning should be thought of as a noun and a verb, right? It's an ongoing kind of a thing, because over a period of time, we're getting new information, right? And so we consistently want to be able to understand that new information and see how it helps to inform planning going forward. So for each of you and your organizations and others that might be involved in this, encouraged to be looking at this and committing to this dynamic process. So step one, and what I'm going to be discussing throughout the workshop, but certainly beginning in step one, we're just going to scratch the surface, really providing the minimal necessary steps to explore possible data sources in your community that you can use for ongoing planning. And then begin with that basic information, begin to make some informed and intelligent decisions regarding some agreed upon strategies and interventions. So, again, through the course of this morning and, through this work, we're just going to be able to start scratching the surface this morning. And part of one of the things I want you to be thinking about and taking away is what that might lead us to understand is that we can't be all things to all people, right? At some point in time, it's very likely that through the planning process, there's going to be a large number of things, of strategies, of interventions that you might be able to impact at some point in time. And I'll talk about one structure to do this later on. At some point in time, though, you're going to have to prioritize, right? As the coalition, right? What are the things that you're going to be actively able to do and to get out in front of? And we'll also spend a minute talking about what can partner agencies do. So we have to begin by asking the right questions to describe suicide problem and its context in a given community. And if we drill down a little bit more by asking the right question, we want to talk about, for example, who in our community is dying by suicide? Who in our community might be experiencing suicidal thoughts that haven't necessarily led to actions, or experiencing suicidal thoughts that led to attempts that didn't result in the individual dying. Along with that question, we want to be thinking about other characteristics that we might be able to gather: age, gender, race, ethnicity, and other characteristics that might help us begin to understand in our community who is dying by or making attempts towards suicide. Equally important to try to understand how people are making attempts or how people are completing suicide, right? What are the different methods that people are using? Is there one or more that tends to be the more prevalent method in our community? Understanding how people are dying in our community and understanding how people are making attempts, just that information in and of itself can really help to begin to explore possible interventions and strategies, right? So the who, the how, but we also need to be thinking about why, right? We need to understand what are any unique risk factors in the community that contribute to suicidal behaviors. So we know there are some shared common risk factors across the lifespan across the United States. And I'll talk about those shortly. But it's not just enough to know those commonly understood risk factors. We need to drill down a little bit more and say, in our community, are there any unique risk factors that we are aware of that we could begin to address? also important in this conversation, and I'll mention this a couple of times, is what's already occurring in our community to address suicide prevention. What resources are available and used and accessed for helping people with thoughts of suicide? For example, gatekeeper trainings and risk assessments and screenings and pathways to care, right? What are we doing in the community to promote mental health and well-being? Because we want to make sure in this planning process and in this conversation that we're not duplicating efforts, that we're not reinventing the wheel. So part of asking the right question include asking, what are we already doing? So in another lifetime, prior to the role I'm in now, I worked for Cortland County Mental Health as part of the LGU. I was the child and the adult SPOA person. And one of my responsibilities also included helping to develop the local services plan. And during that time period, when the planning cycle was in earnest from roughly March until June, you could sometimes, in terms of developing that plan, feel as though you were drowning in data. Sometimes it might feel like that. And there could be this also desire to get more data and more information to inform your planning. But I think it's really important to be thinking about that more is not always better, right? So having more data in this instance for planning is not always the best thing to have available. We need to drill down a little bit and think about the types of data and how we might end up using it.
Hey, Kara, your
Yes.
voice is going in and out a little bit. I'm losing
Sorry.
a little bit. Maybe just wanted, I don't know if I'm the only one.
All right, so I'll try to talk a little bit louder. Thank you for letting me know, Sally. So for planning purposes, when we think about data on the local level, it's really important to be thinking about what's actionable data that we have at our disposal. So once again, another circle here to represent this idea. So we have to start with accessing data. That's the starting point. We have to be able to curate and put our hands on available data that helps to answer the question of who and how, right? It's not enough though, just to access it. We need to understand that data. We need to make sense of it, right? And so ideally, there might be somebody in our community or as part of our efforts who can help us do just that. Help us understand, help us make sense, help that data to tell a story, right? But then lastly, we need to think about, of the realm of data that's available, how can we act on it? There might be some really interesting data that's available in the community, but interesting is the operative word. While it might be interesting, it might not necessarily be actionable. So as you're beginning to think about in this broader lens of developing a strategic plan, knowing it starts with data, how do we access it? How do we make sense of it? And ultimately, is the data we have something that we can plan with? So I believe these charts still exist on the New York State Department of Health website. And if you take a look at this information for a moment, it's de-identified, it's from a county, and you can see that it's the rate of suicide for this county from 2006 to 2015. I'm just using this by way of example. You can see that the rate of suicide in that county from 2006 to 2015 has steadily increased with one small decrease in 2010. So, and this information used to be, and it may still be available for every county. I don't know if they're still updating it, but just using this by way of example and thinking about the previous slide where we need to access data, we need to make sense of it, and is it actionable? If you look at this slide, and if you thought about this in relation to Tompkins County, do you think that this information by itself could be used for developing your strategic plan? I'm going to suggest that probably if this was all the information that we had, that this would probably not be quite so useful for developing a plan around. It does tell a story. It in part suggests that in this county during this time period, there was an increase in suicide. And so for stakeholders in the community, for community leaders, it could be used as a call for action. But for planning purposes, without having any more context, this might have limited value as it relates to doing some real planning. Versus, now this information is taken from the state of Montana from a few years ago. And just to give you some background, in the state of Montana, every year, I believe this is a requirement by law, there is a body of individuals across the state that reviews the circumstances for all confirmed completed suicides. And they produce a report, roughly 20, 25 pages long, with a variety of different characteristics. And so this information, as you can see, one of the characteristics they looked at was suicides by relationship status. So this is over a 3-year period. And then on the right-hand side, you see the most frequent health issues identified in Montana's suicides. And you see that the total was 194 with identified health issues. And you can see that in this instance, chronic pain was the most frequent health-related issue. So if we think back to this slide versus this slide, could you imagine that if we had information in New York State, if we had information in any of our respective counties, such as this, would it be perhaps easier to begin to identify some specific populations and conditions and risk and protective factors that we might be able to develop some strategies around? New York State is improving in the amount of data that we're getting and the types of data that we're getting. We're not there yet. Montana, as you can imagine, it's a huge state geographically. The total number of confirmed suicides every year in Montana tends to be under 300 individuals. So on some level, it's easier to be able for them to drill down to this type of information. So, but I use this by way of example to suggest that if we can get this information or something similar, it can help our planning. There was a question in the chat box, do we get this type of information in New York State? Again, we are getting better. The National Violent Death Reporting System is a federal initiative that I believe all states now are participating in. The attempt is to try and have more of standardization as it relates to reporting any type of violent death, including suicide. Ultimately, that relies on the coroner or the medical examiner, as well as law enforcement, because those are the individuals who are on the scene. And for a suicide, it's typically considered an unattended death. And so there is an investigation. Certain information can be reported. There are some inconsistencies still as it relates to even if something is classified as a suicide or not. For example, in many instances, if there's not a note left behind, even if the rest of the evidence supports and suggests a suicide, in many instances, it will not be classified as such. And so part of the goal of the National Violent Death Reporting System and other efforts is to train coroners and medical examiners to do a slightly more thorough investigation that does not rely solely on whether or not a note is left. Because the research tells us that notes are only left in roughly 30% of instances. So that leaves a wide opportunity to have some discrepancies in reporting. So just spend a couple minutes talking very high level of possible examples of data, again, trying to understand the context of suicide in our community. And I want to acknowledge Sally and others who contributed to some of the next few slides, because I want to begin to paint a picture of what do we know from a starting perspective of suicide completions and attempts and perhaps thoughts in Tompkins County. This is not necessarily the end all be all of information and data that might be available. But in this context, I wanted to make sure that we could at least begin to share a picture. And I also would be remiss if I didn't sort of remind myself and remind others that, this is strategic planning. And I'm suggesting that we have to start with data. We have to start with knowing what suicide looks like in our community. And strategic planning and using data is a big part of what I do and what I've done for a number of years. And so I truly value the importance of data and statistics to help understand the scope and the scale of something. It's necessary to have that information. But I also want to remind myself and just to remind others that behind the data that I'm going to be sharing, behind any percentages, behind any information are individual lives that have been lost to suicide or impacted by suicide. And so I want to respect and honor that this is not just percentages and graphs and data points on a graph. These are individuals' lives that have been touched by suicide. So I think they're both equally important to acknowledge. We need this information to help inform our efforts. But these are individuals who've been touched by suicide. So I'm going to take a look just briefly. I'm not going to cover this in any great detail, but you can see the slide taking a look from January 17 through June of 21. So we're going up to the first half of this year. When we looked at the confirmed completed suicides, you can see that the vast majority were male, and that tends to mirror New York State and the national numbers, that males complete suicide much more often than females. When you look at the age range during the same time period, right, and in terms of how it's broken down, you can see that the vast majority of the confirmed completed suicides tend to be 30 years and older, right, which again, tends to mirror national numbers that, generally speaking, the older populations have higher rates of suicide. So I just wonder for a second, and you can put this in the chat or anybody has any reflections or comments, just taking a look at this information. Is it consistent with your knowledge and understanding of suicides in the community, or does this surprise anyone? Thank you, Brian, for sharing that information. That understanding that in Ithaca College this year, there have been 2 deaths. And so my heart really aches for individuals and for those impacted by those losses.
Yeah, and sorry I wasn't able to give more information about that. I had asked our vice president for permission to do so, but hadn't received it.
Well, no, and that's perfectly fine. And I think just illustrates again, the need to continue efforts. There's a question about the ages 40 to 49 are listed twice. And I understood that as being a total of 10 in that age range. I don't know if there's anyone on the call who can talk to that in more detail or why they were broken out like that. I'd forgotten to ask that before I populated the slide. If we take a look, and again, from a beginning standpoint, there's some good information already available that you all can begin to sort through and sift through and try to understand. When we look at, during that same time period, suicides by ethnicity, you can see that the vast majority were white. And one of the things that you could look to do, or somebody could look to do, is to take a look at the census information in the county to see the rate of suicides amongst Asian Indians or Black and African Americans or Chinese, to see, so we see the raw numbers, but it could also be of perhaps use and benefit to understand the rate, which is the number of individuals per 100,000. So of course you would need to find the demographics in your county to do so. As it relates to that same time period, we saw that one of those 54 individuals was identified as a veteran. We know that in all of this information, the data is not perfect or 100% accurate. And so for any of this, there can be underreporting. So just always important to put that sort of caveat next to this information. If we look at, and this is taken from the New York State Suicide Data Dashboard, if we look at self-harm hospitalizations by county and by age group, and taking a look at Tompkins County, you can see that self-harm hospitalizations not resulting in death, that the vast majority were female, which again is consistent with New York State and the national numbers, that females tend to self-harm more than males, where the result is not dying by suicide or by that action. And then if we look at self-harm hospitalizations by discharge status, and this is 2016 to 18, I believe, you can see that the vast majority of those individuals, the discharge status was home, and with roughly half to some sort of psychiatric hospital or unit, and then other. And I'm not sure what the other might consist of, but with that information, again, from a planning perspective, you could begin to think of, okay, so a good portion of these individuals who are self-harming and being seen in the hospital are going home. Are there efforts, are there opportunities to intercede and impact on that level? When we think about emergency department visits due to self-harm, and this is just 2018, again, you can see the age range that the vast majority of those self-harm visits presenting at the emergency department are in the 10 to 24-year-old age range, which again is consistent with New York State and the national numbers. And also consistent is that the vast majority are female. And again, you can take a look at the discharge status for that information as well. And this also captures self-harm ED visits by mechanism. And so what we're seeing for Tompkins County in 2018 is consistent with state and national data. Going back to the previous slides from that ended in June of 2021, of those 54 confirmed completed suicides, roughly a third were by asphyxiation and hanging. The next most frequent methods were firearms and polydrug overdose, both at roughly 17%. And the remaining methods were varied. And so remembering that when we are talking about understanding the context of who in our community is dying by suicide and how are they dying, that this information perhaps could eventually lead to some strategies or some interventions. Also was able to get some information from the Communities That Care survey conducted by BOCES in 2018. And so you can see that this covered all middle and high school students in Tompkins County with a really good, almost 80% participation rate. Over 30% of students in 7th through 12th grades endorsed the following statement. In the past year, have you felt depressed or sad most days, even if you feel okay? Sometimes highest percentage is being in 10th grade. And almost 20% of students said they would not talk to anyone about their feelings. So you can take a look at the comparison between 16 and 18. And so again, thinking about the youth in your community, these are young people, right? Living life in their community, in school, in the different areas that they live and play. And so this is just that snapshot, right, of their experiences around mental health. And I think, to me, one of the most interesting and telling things is roughly 20% of the students said they wouldn't talk to anyone about their feelings. So with that information, with that knowledge, and recognizing that reaching out for help if you're struggling is really important, especially as it relates to youth suicide, could that data point by itself be an opportunity for messaging? So take a minute now and think about what other types of data might be helpful. And it's really important in this context to realize that we're never going to have a completely 100% complete and accurate picture of all the data in our community as it relates to the context of suicide and self-harm behaviors. You could go on for years trying to gather all of the information, right? At some point in time in the planning process, there needs to be a shared agreement that you've done due diligence and you've done the best that you can. You've gone to the different sources and you've requested and accessed recent data and made sense of it. These are just some other examples of information and data sources that might be helpful to be thinking about as you continue this journey. A couple of things, for example, do we know of completed suicides? What kind of drugs were found in people's system? Do we know suicides by occupation? Are there particular occupations in our community that tend to have higher rates? Do we have self-injury admissions and dispositions from our local hospital? And some of that was on the New York State data dashboard. Do we know the number of individuals with identified mental health conditions? How many people have been touched by the mental health system in the community? Any number of different possible sources of information might help to continue to complete and round out that picture, right? So if folks want to take a second and just in the chat box or verbally start thinking about what data do your respective agencies and organizations use or have access to as it relates to suicide prevention, and or where might you be able to start getting some additional information locally? So if folks, again, either want to unmute themselves or just put it in the chat function, just to begin percolating on what are we using, might it be helpful in this context, and where else might we go? So there's a question from Helen in terms of how does this data get collected? Is the family offering the info after the death? It's a great question. And in part, it really does link back to the individual or individuals who are doing the investigation of a suicide. Are the questions being asked, right? To be able to identify, was this person involved in mental health services at the time of their suicide? Were there life stressors going on? So on and so forth. So part of it depends on, are those questions being asked? Is there uniformity in terms of how that information is being collected? So
can you talk about who collects that data? Maybe, in the county, just to kind of paint the picture of where
sure.
any data would go.
So I believe, and for anyone, please correct me if I'm wrong, but I believe in Tompkins County, it's the coroner system. So it's coroners and law enforcement on scene might be collecting some of this information also, but typically it's going to be the coroner or the medical examiner or a medical death investigator, if the community has that role, that's going to be getting that initial information, age, race, gender, et cetera. And then ultimately, that information is being reported to the local health department, which eventually that information gets fed to New York State Department of Health to be able to help populate the New York State suicide data dashboard. And again, we've gotten better over the last few years as to the type of information that we're gathering and the consistency in which we're gathering it, but we're not there yet. So this is across the state. There's still work that needs to get done. There's a comment here that at Ithaca College, it comes from the Office of Public Safety. And so, right, so colleges and universities are going to have, my understanding is they're going to have their own sort of internal reporting mechanisms on probably a number of different data points, attempts, completions. Another point of data might be for a community to consider how many mental health pickup orders are there that if this information is captured, for example, is because somebody is, there's a concern over suicide. So it looks like BOCES does the local student surveys and would have firsthand data of those results. So this is the type of conversation we really want to start percolating over and thinking about is what's the information that we have? Is it actionable? And again, is there somebody who can help us understand it? One other thing to be thinking about, especially in upstate New York, where the populations tend to be relatively small, with the exception of maybe, some larger urban centers, is to protect confidentiality. It's generally best to be looking back over 3 to 5 years, whatever our most recent data is, to be doing a 3 to 5 year look back as opposed to just 1 year, for example, because in the course of, say, 1 year, especially if it's more recent, and the numbers are relatively speaking small, and that's why you saw on one of the previous slides, it said numbers are suppressed because smaller numbers. It might be easy to identify, oh, that was June of 2019, a 20-year-old, and people might recall specific circumstances. So again, we really want to make sure that we're balancing safety and that we're balancing privacy. So ideally, we're taking at least a 3 to 5 year look back when we're looking at a lot of this data and information. So this is a New York State suicide data dashboard that I referenced. The veteran suicide in New York State is another source. These are just by way of example. Again, in the community, you all might have a number of other sources, some of which were just mentioned in the chat, that you could begin to curate and access and begin to understand. So I'm going to pivot in a second to step 2, which is based on that data, how do we begin to discuss and understand long-term goals? But before I do that, and most of the workshop is quite honestly focused on the data and the context. The other parts go a little quicker because it really has to start with a shared understanding. You could imagine that just step 1, collecting the information, collecting the data that we have about who and how and where, if we can get that information, right? Any of that information, that's going to take a minute, right, to be able to curate. And so you could probably also begin to imagine that not only is it going to take a minute, but it's going to take some people to access that information. And so in my experience for other communities that have engaged in the strategic planning process, they have found that having a dedicated group that maybe is very time limited, but looking specifically at this question about data is one way to proceed. It's not the only way to proceed. And ultimately, you all know best the conditions in the community that are going to help advance this project. But for what it's worth, one way to consider it might be, can we have a small work group of individuals who are going to help do a little bit more digging, get some more of that information. Maybe we have a student from university be able to help then make sense of that data and that information, put it in a package, so to speak, that could be presented back to the larger group so that we have that shared understanding of step one. What do we know about individuals in Tompkins County that attempt suicide or die by suicide? The analogy, or the example I think of sometimes is a few years ago in Albany County, after making this presentation to their coalition, they actually got I think it was a SUNY public health student to take the information that they were able to get and put it in a very digestible PowerPoint presentation, which they then presented to the full coalition to sort of end step one of their strategic planning and have a discussion around long-term goals, which is what we're going to be pivoting into right now. So long-term goals, just to start with a shared definition, they are something that provides reductions in suicidal behavior, maybe in a specific group of people, or they might be goals associated with a specific risk factor or a specific protective factor, or they might be something that attempts to reduce suicide behavior in a certain setting, right? So those are just some very high level examples. So for example, examples of long-term goals might be reduce suicide among Latina youth, or reduce suicide attempts among adolescents in the county, or reduce suicidal behaviors among youth involved in the child welfare system. Those are just some examples that hopefully would all have been linked directly to the data of a given county. Now, one thing that's missing for all of these long-term goals is we have no way to measure success, right? And so then that's intentional. I want people to be thinking about, as you proceed in this developing of a strategic plan, we want to be as specific as possible. Reduce suicide among Latina youth by how much, right? So really important to make sure that we not just identify the goal, but how are we going to know if we've arrived? Things to be thinking about as you consider choosing your long-term goals. Are there resources in the community that can be directed at that problem? You may have data that has led you to believe that here are some areas that we can try to impact. Here are some long-term goals. But if the consensus within the coalition is we don't have resources that we can direct towards those right now, then you're going to have to discuss, is that a long-term goal that we want to try to actively impact right now? Excuse me, you also need to consider, do we know enough about the problem, about the area of concern to take effective action? So if we go back to the example of reducing the number of Latina suicides in our community, do we know enough about that? Do we have enough information that we could develop strategies and have resources available to address that? That's really important, those two questions to be thinking about. Ultimately, important anytime we're developing our long-term goal, is there a link back to the local data and context, right? We always want to be able to walk it back and say, we developed this long-term goal or these long-term goals based on the data and the information that we have at this point in time. And so based on that data, I would suggest that it's likely as a community, as a work group, as a coalition, you might be able to identify upwards of, say, 3 to 5, and that's not like written in stone, but you might be able to identify, say, 3 to 5 potential long-term goals based on that data. But then that by itself could be pretty overwhelming. Give yourself permission to brainstorm, start big, but then refine down. Maybe discuss, of these 3 to 5 long-term goals, we are going to specifically prioritize 2 to 3 long-term goals to focus on, right? Because it wouldn't be unusual to identify a number of possible long-term goals, but you've got to start someplace. And there's any number of different ways you can come to that decision-making, right? When we think of long-term goals, it really should be something that's focused on a group that we might be able to reach where suicide or self-harm is prevalent, or perhaps it's on a particular means or method that is prevalent. And that second item there, a long-term goal looking at a specific means or method, we know that lethal means safety. Intervening before thoughts become actions is one of the most effective ways to prevent suicide. So for many communities, they begin to look at, amongst other things, how are people dying in our community? And of those prevalent methods, what does the research tell us about effective ways to impact that? Part of a long-term goal might be looking at a specific risk factor that we might be able to modify within the community, or a specific protective factor. And ultimately, our long-term goals should be using the SMART, acoustic, specific, measurable, attainable, realistic, and time-bound. So before I go to step 3, right, in this idea of developing the long-term goals, the data has informed that process. Again, in my experience, oftentimes what coalitions will do, this smaller work group will make recommendations of, here are the 3 to 5 long-term goals we might want the larger group to consider. And bring that back to the larger coalition. And then you can have any number of different ways to try to prioritize, right? You can give people monopoly money and they can spend their monopoly money any way they want on these goals. There's a number of different ways you could be creative in terms of how we are going to prioritize. So a question, in collecting data, wouldn't most of the deaths be available from the county medical examiner? Absolutely. I mean, they are the individuals who are collecting that information across the state, whether it be, again, coroner or medical examiner, right? Those are the individuals that have that information. And in my experience, again, across New York State, everybody has a different understanding of why that information is needed, right? And so some people, and you can imagine, a lot of very valid reasons for this, right? Some people are very protective of that data, and they want to make sure that they're not jeopardizing confidentiality. And so in some instances I've seen around the state where medical examiners or coroners can be reluctant to share the type of information that I'm talking about to help with strategic planning over concerns of confidentiality. And I totally understand that, and I get that. In my perhaps naive way of thinking, it's not all or nothing. In my way of thinking is, we don't need to know specifics about individuals. We need to know some of these characteristics. And quite honestly, it's more helpful to have that information over a period of time so we can perhaps look at or understand, are there any trends? Is there any movement in one way or another with certain demographics and characteristics. We don't want just 1 year. That's probably not helpful, not just as it relates to suicide data, but any kind of data for public health. And so it can become a process to help engage, again, medical examiners, medical death investigators, coroners, as to why it's important to have this information and how we're going to use it. It's an extremely important question, but I think there are opportunities, if people are reluctant, to try to help have them understand the way in which we're going to be able to ultimately use this information for prevention.
Hey, Gara. So I wanted to let folks in the coalition know I had some contact from Jen Edelman, who is the chief death investigator for Tompkins County Office of Medical Examiner. And she has expressed her interest in wanting to be involved in the coalition and to offer her perspective. She was not able to join us today, but she's very interested in being part of the coalition work. And it seems that she would be able perhaps to be helpful to us in determining how we might be able to get more of this data.
Wow. Yeah, Sally, that is fantastic. Provide sweets and treats and whatever you can do. No, I think that's, those are the types of roles in a given community that we want for any number of different reasons, right? But somebody with that background, with that experience, who can be the champion in many respects to help curate some of this information can go a long way, right? To further understanding those data points in our community and accessing that data over a period of time. So that's wonderful news, and hopefully that will come to fruition. So eventually, right, the goal would be for the full coalition to agree upon those, say, 2 to 3 long-term goals. The next step is to start looking at key risk and protective factors that link to those long-term goals. So protective factors are characteristics of people or environments that reduce the effect of risk factors and thus protect people, or can protect people from that risk. Risk factors are characteristics of people or environments associated with an increase in a health-related condition, and so such as in our instance, suicide behavior. So just to have that shared language and definition. So this is really the public health model to suicide prevention. As it is with many public health issues, we're seeking to identify those risk and protective factors and prevent that condition, self-harm or dying by suicide. Prevent those conditions by decreasing risk and increasing protective factors. The more risk and protective factors that we're able to impact and change, ultimately, the more effective our prevention efforts will be. But, and this is really important, since you, and you meaning the coalition, since you can't do everything at once, and you can't be all things to all people, in this context, in this planning conversation, you really need to be strategic in choosing which risk and protective factors to address. So in my experience working with coalitions, whether it be from a strategic planning process or from a activities and a strategies related process, that one. Sometimes the coalition takes the lead on certain initiatives, right? So that slide or that graphic to the left there, the coalition is out in front, and those member organizations that comprise the coalition are there in background, are there in support of the coalition. So, it might be the Tompkins County Suicide Prevention Coalition is sponsoring X, Y, and Z. So in that instance, the coalition is out in front. But at other times, right, the coalition is shining the spotlight on one of the partner or partners in the community that are working to advance some of the goals and some of the strategies, right? So it's important in the strategic planning framework and discussion that early and often there are discussions around, okay, where do we see the coalition having the bandwidth and having the capacity to be out in front for any of these things versus what of the goals and interventions that we've identified can our partners take the lead on? Or maybe they're already working in that space. How can that work be enhanced and expanded? So those are important conversations to have throughout the planning and implementation process. What do we see as realistically that the coalition can do, recognizing that you're all volunteers, recognizing that this work is happening in the context of your day jobs and everything else you have going on? Where do we realistically see the coalition being out in front versus the Tompkins County Suicide Prevention Coalition would like to spotlight our partner, whoever it is that's doing this work? So those are things you want to be thinking about throughout the course of developing the plan and implementing it. So what do we know about key risk and protective factors within suicide prevention? So that we know that some of the most significant risk factors associated with suicide across all populations are a prior suicide attempt, any type of alcohol and other drug use, mood and anxiety disorders, especially depression and bipolar, and access to lethal means. For example, prescription medications or firearms. Those are significant risk factors for suicide across all populations, right? Not specific to any one county, but this is really across all populations. When we think about key protective factors, significant protective factors against suicide, right? We know that effective care for mental, physical, and substance abuse disorders is a significant protective factor. We know that connectedness to individuals, family, community, and social institutions, and problem solving and coping skills are all significant protective factors. That's across, right, all populations. And so just knowing that information without anything else, you could begin to think about, okay, what do we know about availability of connectedness to individuals, families, community, and social institutions in our county? Is there equity in terms of how people are able to connect to these opportunities? Do we teach our young students in school problem solving and coping skills, right? So that just that information by itself could be helpful. But then besides knowing those global risk and protective factors, and once we understand those, we also need to ask ourselves, but why here? Are there additional risk and protective factors that might be unique to our community that might have an impact on our long-term goals? So that might include such things as, are we experiencing higher rates of depression in our community compared to our neighbors? Or do we have a lack of access to services? Or do we have a higher access to lethal means? So again, posing this question about what do we know about specific risk and protective factors in our community, that begs the question, what are some sources of information to help us determine some of those risk and protective factors in our community? Some great comments from Carolyn. Housing insecurity and income inequality and economic stressors in general, right, are all absolutely risk factors, and the greater degree to which they exist in a community can very much so be a risk factor that can impact risk to suicide. And so there's actually been a good deal of work happening, slowly beginning to happen, around the state, looking at that intersection of economic instability, housing instability, and whatnot, and how can we impact that? How can we educate people working, say, within those fields, right, to be able to perhaps connect around the topic of suicide? So the question I just posed was, what are some additional sources of information? This slide is a few years old. It's from the Prevention Agenda 2018. I don't know, and apologies that I did not explore this before the workshop. I don't know if this level of information is still available on the New York State Department of Health website, but up until at least 2018, there were any number of different prevention agenda indicators that you could look at by county to see how your county stacked up on any of those indicators versus New York, the rest of the state, and the prevention agenda benchmarks for that time period. It was a very interactive website. I hope it still exists and has been updated. But you can see that one of the categories there is promote mental health and prevent substance abuse. So item 42, age-adjusted percentage of adults with poor mental health for 14 or more days in the past month, or age-adjusted percentage of adults binge drinking during the past month. If we began to collect and understand that information, which really ultimately asks or begins to answer the question, but why here? Are there unique risk and protective factors in our community? You could begin to see how that information could help us further narrow down potential areas of focus. So I'm going to pause there before going on to step 4. I always try to do a brief recap to make sure that we're sort of on that level set, right? We start with the data, we understand the data. It helps us begin to identify those long-term goals. We start to look at risk and protective factors, both globally and in our community, right? That might be something that can be impacted, those long-term goals. And so going back to my, one of my initial thoughts or wonderings is, again, somebody has to take ownership and responsibility, not just for collecting the data on who's dying in our community, who's making attempts, et cetera. But this last portion also suggests that we need to have due diligence at some point in time in the process in trying to collect some of those local risk and protective factors. So for example, the local services plan for mental hygiene, right? Some of that data likely exists that could be explored and looked at and see how does it fit into this context. The previous slides for Tompkins County Communities That Care data, those questions aren't necessarily specific to thoughts of suicide or attempts, but they do look at some of those risk and protective factors. Do youth feel connected? What are youth experience with substance abuse, so on and so forth, right? Getting that type of information and finding out what else is also available in the county can all help you further articulate what do we know about risk and protective factors relative to suicide prevention in our community. Again, ultimately, we have to have a shared decision that we've done due diligence. We have a good understanding of those local, especially conditions, those local risk and protective factors. That's going to allow us to pivot to step 4. Select or develop interventions based on those risk and protective factors. So from a common language perspective, intervention is an activity or set of activities designed to decrease risk and increase protective factors. So for example, and these are just very generic examples, right? Providing bus vouchers so people can get to mental health care professionals. that increases access to mental health services, which is a protective factor. So I'm just going to stop at that example for a moment. And let's say that was something that your community decided made sense based on the data, based on risk and protective factors and your long-term goals, that you were going to encourage increased utilization of bus vouchers so that people could get to mental health services. You all, as part of the coalition that were part of the process to identify that as a specific intervention, absolutely understand the context. You can absolutely begin to understand the linkages back to impacting suicide. But for people not involved in the coalition, they might question, well, what do you mean your suicide prevention coalition wants to provide bus vouchers so people can get to mental health? How is that suicide prevention? That wouldn't be an unusual question or wondering. It might even come from partner agencies. So what do you mean you're promoting use of bus vouchers? And so I want to spend a second just to suggest that each and every one of you, your colleagues, anyone who's involved in the planning process, as well as the implementation process, right, are ambassadors to this work. And you should be able to respond to those questions. If people are wondering, well, why is your coalition involved in X, Y, or Z? That's a fair question. You should be able to walk it back. Where did this strategy come from? How did we get here? And that's going to do any number of different things, not the least of which is, hopefully, it's going to provide more of a shared sense of why the work that we're doing and engaged in is important, and also portray this idea that suicide prevention is more than just one thing. It's not just a, quote, mental health thing, right? That suicide prevention is everybody's business, right? So some of the interventions and strategies you identify at the surface, again, might not seem specifically related to suicide prevention. So if you get asked those questions, you want to be able to provide that elevator speech, so to speak, that is able to respond. Another intervention might be packaging prescription drugs in smaller amounts, say in those blister packs, in smaller amounts than are needed for a fatal overdose. Restricts the access of individuals experiencing suicidal thoughts to lethal means, which is a risk factor. Teaching young people self-regulation and problem-solving skills. That increases their ability to cope with emotional crisis, which is a protective factor. And again, these are all just some very generic examples. When we think about selecting interventions for our work, right? Of course, they should be connected to the risk and protective factors, which are linked to the long-term goals, which are linked to the data. Those interventions or strategies should have some evidence of effectiveness. Now, some is the operative word, and I'll talk about that a little bit more by way of example in a second. Those interventions and strategies, they should be approaches that our community can get behind, right? And of course, those interventions and strategies are something that could be implemented, right, and measured. They're not just theory. There is an understanding of how we can take this idea and implement it in our community. So I mentioned in one of the earlier slides with step one, understanding the context of suicides in our community, the very last step was basically what is already happening in our community so that there's a shared understanding of that. This is really important to integrate into the planning process, especially at having this information while we're in the process of identifying interventions and strategies, because we don't want to reinvent the wheel. We don't want to duplicate, right? So there is undoubtedly a number of different suicide prevention related strategies and interventions that are happening in the community right now at this moment in time. And so it would be really important to have as complete and comprehensive a list of what those things are, so that when we get to this point in the planning, let's say we've identified a handful of strategies, we can compare that with our list of what's already being done. And if there's some overlap, if there's some similarity, then in essence, maybe we're not starting from scratch. Maybe we're reaching out to wherever that work is happening and trying to support it and enhance it and expand it. So I would suggest that, and this can happen electronically and it can be a fairly easy lift, I think, is to reach out to everyone who's involved with current coalition activities and begin to have people take credit for the work that you're doing, right? What's already happening in our county? Are there zero suicide efforts? Is there a suicide walk? Is there gatekeeper training? What are the youth and school and campus efforts, right? You could do this through a Survey Monkey. Again, you could do this electronically, any number of different ways. But I would suggest really framing it in such a fashion that is encouraging people to take credit, to shout it from the rooftops, the work that is happening, and also to think broadly. If the question is, what are you doing in the lens of suicide prevention in our community? We don't want people thinking solely about formal connection to mental health resources. That's part of it, absolutely. But going back a couple of slides and a couple of comments ago, are you doing any type of screening for, with economic advisors or anything like that? Really want to be thinking upstream and broadly. What are people doing that impact those risk and protective factors? See a question, at what point are context experts part of the planning? Is the idea that they're involved in the process from the beginning? Excellent question. In terms of when are we looping people in? Because this is an iterative process, right? That's probably, and I'll talk more about possible timelines towards the end. I think in my experience in talking to coalitions that have embraced and engaged in the strategic planning process, you're certainly going to have people at the beginning whose expertise and interest is in that data collection, curation, making sense of it, and making some initial recommendations perhaps on those long-term goals. So it's not unlikely that you're going to have folks that gravitate towards that because of an interest and an expertise. As it relates to bringing in those content area experts for planning and creation of interventions, I think generally speaking, that's when part one might be literally just opening it up to the broader coalition. You're at a point where you're ready to present your findings up to this point. And I'll talk about what that might look like in a second. But that could be a point where you invite people in. And you could imagine that there's going to be sort of two things that might happen. You're going to look at what are the existing strategies that we could use versus, is there a gap? Did we identify something and we haven't found anything intended to address that risk and protective factor? So we need to come up with something locally. Again, that might be an area where certainly, it would make sense to try to invite people to help brainstorm around that. I think quite honestly, the other answer to that question is to have those conversations with the coalition when the need is there. I see a comment here about working in small groups. So, right, what are the buckets, as it were, right? What are the buckets that we want to sort of divvy people up into in terms of clinical, more formal resources, and talking about what tools are available there, looking at more informal resources, thinking about faith communities, for example. Do we have the faith communities reflective of our county represented, and what are they currently doing and what can they do? These are all like wonderful questions and reflections to start thinking about. So this is just sort of a placeholder, I guess, this particular slide. And again, you could start this quite honestly tomorrow, by formulating a couple of questions. And I'm happy to work with Sally and anybody else about the wording that you might want to consider using. But I would suggest that earlier on in the process, you take inventory. The other thing that's going to do for you, quite honestly, besides specifically in relation to strategic planning, is, sometimes we get so busy in the day-to-day work, right? Regardless of what that work, how that work is connected directly to suicide prevention or not, that it's easy to sort of get lost and forget about all of the things that are happening in the community related to suicide prevention. So I could imagine, right, collecting this information from community partners, casting a wide net, right, and beginning to sort of curate those efforts that are happening, not only for strategic planning, but to celebrate and to share with community partners and to share with leaders. Look at all of the things that are happening in Tompkins County, individually and collectively, to help address suicide. This work is hard, right? It can be demanding emotionally, right? We need to celebrate the work that is happening, not to rest on our laurels and say, okay, we've arrived, right? But I think it's important in this work that we make space to acknowledge all that's being done. And so I think that can serve sort of that other purpose as well. So I'm going to just provide 2 local examples of interventions. And remember, I suggested that they should have some evidence base to support them, right? And so lethal means safety. Erie County Suicide Prevention Task Force actually got a little bit of seed money from us a few years ago. We created some funding opportunities for very targeted suicide prevention activities. They chose to work on lethal means safety. And one of the examples they did was a mapping of firearm storage options and an accompanying video in their county. They had an intern last year in the height of the pandemic, I believe it was in July or August, randomly start calling different firearm clubs, shooting clubs, retailers, businesses, et cetera, in Erie County to find out, are they able to store firearms for a period of time if somebody wanted to be able to bring those firearms in. They have an interactive map, right? I'm hoping that they're able to update that, right? But the idea behind it is, right, firearms are the most lethal method for suicide. And if somebody is vulnerable and having thoughts of suicide, or somebody's worried about a loved one who's vulnerable having thoughts of suicide, and they have easy access to those firearms, that if we can remove those firearms temporarily, right, we know that for many individuals, that can be life-saving. And so, and again, I'll be sending the slide deck out. You'll be able to click on those links to see those examples. That is a well-established evidence-based intervention. However, sort of the counter to that is in Wyoming County in 2012, Wyoming County was trying to figure out how can we reach one of the high-risk populations in our community, which was middle-aged and is middle-aged white men. That's a hard demographic group to reach, right? And so as they were doing some planning and brainstorming, happened to be leading up to hunting season in October, and they realized that for many middle-aged men that were hunters, they would congregate at the local Stewart's or coffee shop prior to going out in the woods, right? They'd get together, they would get prepared to go out hunting. And so the coalition folks realized, hey, here's this sort of captive audience, right? Guys are congregating before going out. And so they started reaching out to local restaurants and encouraged them for 2 weeks to disperse information about suicide prevention, about wellness, about where to get help. And for customers who took that information, they received a free cup of coffee with a coupon that had details about information and resources. Now, the money came from, again, a project that we supported, and they found it to be really successful. So it was basically an exchange for people coming into the coffee shops or the restaurants. You know, we'd like to encourage you to take this coupon for a free cup of coffee. In exchange, we're going to give you some information on what are the resources in our community. What are some things to look out for? And they had their third annual Cup of Joe in 2014. In 2018, they took Cup of Joe to the neighborhood. They called it Cup of Joe on the Go by encouraging the community to share a cup of coffee and conversations with a neighbor. I share that example because you will not find that in any best practice evidence registry. It was a homegrown, if you will, intervention intended to meet the needs of their community. High rates of suicide amongst middle-aged white men. And there is an evidence base, if you follow it back, in terms of increasing protective factors, right? Having people connected to resources and information. So by way of example, that was something that community decided to develop. It's been such a popular thing that's actually expanded to other counties across New York State. See that idea that home root can be some of the best ones, right? There are creative individuals that are part of your community that could absolutely identify the needs, look to see if there's already strategies in place, but also develop something, right? If that was the decision. So as you start to identify possible interventions, it's okay to start with a larger list. In fact, I would encourage you to start big, start with that larger list, but also recognizing that that list is going to be narrowed down. It's going to have to be narrowed down. Going back to that slide of, you know, how much is the coalition taking the lead on? How much can our partners do? So it's okay to start big, recognizing that you are going to have to narrow that down. Of course, your interventions need to be tied to the strategic planning process. I would suggest that during this stage, collectively, you begin to identify some quick victories that the coalition can achieve, right? So what's the low-hanging fruit? And I think that's important because, as I'm sure you can guess, you know, strategic planning is not something that you're going to accomplish in a week. It's going to take a little bit of time. And if you think about your coalition, and if you think about the people who are currently engaged and people that might want to be involved down the road, there are some people who quite honestly could probably care less about strategic planning. They might want to get involved with a suicide prevention coalition because they want to do something. They want to be part of the tabling events. They want to be part of organizing things. They want to be some of the quote implementers. And they probably might describe themselves as having no interest at all whatsoever in strategic planning. And for some people, right, they might think like, well, why do I want to be part of the coalition? All you're doing is talking and talking. Nobody's doing anything, right? And so it's important to identify and having a shared conversation around this is what are some things that we can sort of do in the short term that we all believe have value and impact, right? And or what are the things that we are already doing that we want to continue so that it's not a matter of we have to wait for the plan to be done before we do anything versus we don't need a plan because we're already doing things. We want to find that balancing point. Just as I assume there are people who are going to engage in and embrace the strategic planning process, and that's part of the contributions to the coalition, but some folks might be less inclined to be out in front of things, to be that public face. So again, as you're developing and or identifying strategies, thinking about are there quick wins? So if we think about how are we going to take the world of possibilities, the world of possible interventions and strategies, and begin to sort through them and to prioritize them, this is one way to consider doing that. You're certainly, whatever process works best for you all. But what I like about this is it can be a relatively quick way to start sorting things. So again, I mentioned a moment ago, start big. For those risk and protective factors that you've identified, start identifying as many possible interventions and strategies for any of those risk and protective factors. That's step one. Then step two, and I've actually done this in person before with blue painter's tape and colored Post-its, right? So if we look at the upper left quadrant, right, we have strategies that are low effort. They don't take a lot of maybe money. They don't take a lot of staff time, but they might have high impact. So we could think about those as quick wins, right? If we go to the bottom where we have low effort, so again, not a lot of resources, but also by using those strategies, we would anticipate that the impact is going to be relatively low. We might think of those as sort of those fill-in activities. We could also think about those as things that would be easy to get behind, again, because they don't have a lot of effort involved. If we go to the upper right, we see big projects, and that's where we have a high effort. It might require a decent amount of funding or amount of time or amount of resources or all of the above. But we would also expect a decent return on the investment, a high impact. Those are those big projects, right? And then the bottom right, those are the activities and strategies that are both high effort and low impact. And so you can see how those are framed as the quote, no thanks interventions. So how I've seen this work in person before is you have everybody write down on a sticky pad one strategy or intervention, right, per sticky pad. And again, you can have as many strategies or interventions for risk and protective factors as you want. And then people go up and place, this is sort of on the honor system, but thinking critically, where do I think my strategy or intervention fits? Is it a quick win? Is it a big project? And if you did that for each identified risk and protective factor, it takes a little coordinating, right? A little orchestrating. But if you did that for each, visually, right in front of you, right, you would have a pretty good picture of, oh my gosh, everything's in the big projects area. Is that realistic for us to be able to proceed if all of our strategies and interventions take a lot of effort, even though we believe return on the investment will be positive, right? And so that's one way to consider conceptualizing how you might prioritize things. The other thing that you could consider doing is not just putting those Post-it notes with strategies or interventions per risk and protective factor, but also you could do it in such a manner, maybe color coding, whatever it is, that indicates, do we see this intervention or strategy as something the coalition is taking the lead on? Or do we see this intervention or strategy as something one of our partners can take the lead on? Maybe they're already doing it, whatever it is, right? And so this, again, is one example of how you can start organizing those. So another way to think about what that might look like eventually is using the theory of change logic model. So if we start on the left-hand side where the problem is, rates of suicide amongst whatever population in our county, right? If you thought about plugging the problem or the long-term outcomes we're looking to impact in that box, with whatever data source we have to support that. And then moving left to right, we think about the root cause, right? But why, right? What do we know about that particular problem? We articulate that. And again, whatever data we have to support our understanding. Then moving to the green box, but why here? What are the local conditions, right? We identify those data sources. And then if you look at this generic model, for each of the local conditions, right, you begin to identify, you do that brainstorming of strategies and interventions. You do that for each of those local conditions. And the way the theory of change logic model works is that even though we start left to right, by implementing those strategies and interventions, the belief is that it will begin to impact those local conditions, which will then begin to impact the root cause, which will then begin to impact the problem that we've identified. So we start building it left to right, but with implementation, right, we're going to begin to work backwards, as it were, and impacting some of those larger areas. Again, this is not prescriptive in nature. There's any number of different designs for logic models. You all will decide what works best for the community. So here's just one example, very, very non-detail oriented, but one way you might think about it, right? So the problem statement is, the suicide rate in our county is, but why? What's one thing we know about it? Well, access to lethal means. But why here? Well, a lack of education on safe gun storage programs. So one intervention or strategy might be to use a national model for gun safety projects. Again, just a sort of generic example of how you might use that theory of change logic model to inform and encapsulate your work. Evaluating your efforts is really crucial. If you're going to spend the time and the energy to develop the strategic plan, you want to know, is it having the impact we intended, right? And so the evaluation, and this is where you might bring in other people that have expertise specifically around evaluating efforts, right? And the value of engaging this exercise is, you're going to be able to identify and solve problems. Ultimately, you're going to be able to make a determination, is progress being made, right? Really important, by having some method to evaluate our efforts, it can show our partners, our stakeholders, policymakers and funders, and the community in general, the value of suicide prevention efforts if we can show some impact. And it can help us decide how to enhance or expand our efforts. So I'm not going to read through everything on the right-hand side in terms of what an evaluation plan details, right? These are fairly standard, uniform points that we would want to think about from an evaluation plan. And again, depending on the website, depending on the resource, right, you'll see some differences and you'll see some similarities when you're developing an evaluation plan for your efforts. But these questions and these points are all really important to consider. Once you've identified those interventions and strategies, what's the evaluation plan going to look like? So some evaluation questions might look like, let's say that we want to have protocols to have safety planning protocols for anyone who comes into the emergency department, right? So the questions might be, have the protocols been drafted? How many people have been trained in those protocols? Why were some people not trained? What percentage of social work staff was trained? This is, again, just a brief, very generic example of if one of our interventions was to develop safety planning protocols to be used in the emergency department, these might be some sample evaluation questions. Again, this takes a minute, right? It takes focus. It might take a small work group. Somebody might say, I can draft an evaluation plan for these areas. it's going to be an iterative conversation. But I would strongly encourage folks that if you're going to spend the time up to this point to develop those strategies and interventions, that you're best served by taking it to this next level of those evaluation questions. And then step 6 is implementation. There's got to be an action plan, right? And that action plan is going to basically be a roadmap, a step-by-step description of what has to happen. Again, there are a lot of different templates and examples. Most action plans consist of some of the following components. What are the different tasks that we need to do, timelines, who's got primary responsibility, who else do we need, who's missing from the table, any number of different things. And as I think I mentioned before, I have some exemplars I'll share after the workshop. You can choose to use them or not, but just by way of at least starting the conversation. Also thinking in terms of implementation, another way to think about it is, where are we going to focus our efforts? Is it at the individual level, all the way up into and including public policy, right? Where do our strategies, where do our interventions fit in this concentric series of circles? So it might be helpful to think about your interventions using something along these lines. So that was the last point in the structure for strategic planning. And I'm hoping that, this has whetted people's appetite to say, okay, yes, this is something that we can figure out how to advance and how to develop ultimately. But in the same light, it's also important to understand that even if you all agree that it makes sense to engage in a strategic planning process, to at least have a general understanding of, so what might get in our way, right? And any number of different things might be speed bumps or barriers, right? Having a plan simply for plan's sake, right? That's probably going to have limited value. Only having a partial commitment from the coalition, right? So again, I would suggest that trying to involve everybody who sees themselves as part of the coalition for every step of the way could be cumbersome and could take a really long time. So it's finding that balance of having maybe a small group that starts the work, brings it back to the full coalition for discussion, goes back and continues the work in that iterative process. Might be the most effective way to do it. You all will decide what works best, but ultimately we need everybody's buy-in that this is important, because the other thing that allows us is we all have a voice. We all have skin in the game, as it were. We've all had the opportunity, at least, to be part of this on some level. Another thing that could get in the way is not having the right people involved. And not having the right people can mean other things, right? Do we have somebody that helps us understand data? Do we have somebody who can help us understand implementation? There's any number of different ways to understand whether or not we have the quote right people or not. So again, that's probably something that you would figure out in time. Something else that might get in the way of planning is just writing the plan and then popping it on the shelf. And I'm sure you've probably all been aware of, or maybe been part of processes before, where there's this energy and excitement around writing a plan. And then a year later, people are like, whatever happened to that plan? And is anyone doing anything with it, right? So it really needs to be dynamic in nature. Your plan might identify things that are new strategies, new interventions. It might be looking at doing things differently than you've done in the past. And if there's an unwillingness or an inability to change, then your strategic plan and that roadmap might be limited in effectiveness. And then lastly, unrealistic goals or lack of focus might very well be a stumbling block for strategic planning. So, we're getting closer when you see that heading, right? Yet another circle that we have, you want to be thinking about planning, about implementing, about checking in, right? Are we headed in the right direction? And then, based on that information, to revise. So it's sort of that cyclical process. But we also need to make sure that we're being flexible. So strategic planning by its nature is suggesting we're going to use data to inform our work. And we don't want to do it in such a fashion that it feels like whack-a-mole, right? That we're like sort of chasing things. We have a plan and we feel good about that. However, we also need to remember that circumstances could change, right? And so with that in mind, we want to have a shared sense of flexibility, that if we're in the midst of our 3-year plan, but we get some increased data and information that suggests an increased vulnerability, we don't want to be thinking, oh, well, that's not part of our plan, we can't address this now. We do want to have that sense of flexibility of, okay, we have new inputs, we have new data, what are we going to do to address that? So what's next? Very high level suggestions in terms of what you might want to consider. I think, sad to say, but maybe having a follow-up meeting, right? Considering some of the following, starting with like, is there value in developing a specific work group, looking at collecting that data and managing it? And maybe just broadly, in a more broad sense, having the focus of the strategic planning. Probably short-term in nature with a very focused goal. Start thinking about what other data do we have? And there's been some good discussion in the chat. I think people are starting to percolate and think about, well, what's the data I have and how can that help inform this? Thinking about who's missing from the discussion. Are there local colleges or universities, again, that might help support any of this planning work? And I don't know about yourself, but I find that if I don't have a timeline in place, the ball can keep getting kicked down the road. So I would suggest at least coming up with a rough timeline of when we hope to have the data presented, when we hope to have the long-term goals presented, and ultimately when we hope to have a final plan to present to the full coalition. So a lot of information I fully understand in a short period of time. If in the chat box, folks wouldn't mind, and I know some folks have had to hop off, but identify one thing that you bring to the local suicide prevention coalition efforts, and one thing I hope that folks will take away from this workshop. You can write both, either or, doesn't matter. So I'm going to stop sharing in a second, but there is your request as we get ready to wrap things up. And I want to see if there's any thoughts, questions, or concerns. So in the chat box, one thing you bring to the local coalition efforts, and one thing that you hopefully have taken away from today's workshop. And as we're doing that, certainly want to open it up to any questions that folks might have. Thank you for that comment, Beth. Absolutely agreed.
I guess I want to say before everyone has to hop off, I'm just really impressed and grateful for all the folks who spent this time this morning together, focusing on kind of a process that we're continuing now. And I guess I'm energized by even just the ideas that have come up during this time of, yes, we can get an inventory list together. Yes, there's a small group that already wants to form to talk about interventions. Yes, we've got a great contact in the medical examiner's office. So I feel like there are already kind of steps that we're taking in a really positive direction that will help us move towards some of those quick wins that you talked about Gara, it really seems important to make sure not to lose sight of really establishing some possibilities that will keep forward motion. I think that's what I'm about, and what I'm hearing is the need for forward motion. And I think that so many people showing up today to be a part of this conversation shows that there's a lot of energy for forward motion. And I will be reaching out to everyone, as I did prior to the meeting, about the next steps and about who's able to begin to form some of those smaller groups that we talked about for a short time, to then be able to pull some information back to the larger coalition. So again, I'm grateful to have the involvement of so many different folks from the community, and that there is a need to continue to look for that involvement from everyone, from the context experts to the data experts to the content experts. That the hope would be we'll continue to look for that involvement at every step.
I so appreciate that reflection, Sally. And to me, that's the exciting part about this, is it doesn't just have to be one or two people, right? Every one of you who's on the call now and who's been on the call, we can all contribute, right? We can all play a part. And to realize I don't have to shoulder this all on my agency or organization, what a relief, right? That would be a lot, but all of you collectively, that's empowerment to me, right? And so, yeah, thank you for that. And for everyone, well, this is a great turnout, right? You will find your way, I think, and Sally, correct me if I'm wrong, but I'm happy to continue to sort of be in the background to provide whatever's helpful. I'm also happy to get out of the way and let the work unfold, right? But I'm here for you. I'm also a neighbor, in that I live in Lafayette, so Central New York holds a special place in my heart. But my role as statewide is to connect you to resources and information that I can assist with. Ultimately, though, the real work begins like now, when you all have to sort of take this information and synthesize it. So yeah, thank you all.
Well, thanks everyone. I hope you have a great rest of your afternoon, and I'll be in touch, and we'll find ways to move forward together.
All right.
Thanks.
Take care, be safe, take care of yourselves.